Okay, so you already have the PowerPoints on Canvas, the introduction and this one, which is the one that has to do with the inflammation and cell injury. And hello. Yeah. Hello. And we are going to start with this part, the second one, the one for inflammation, cell injury, which forms the basis of pathophysiology. Probably during the summer semester I told you sometimes, okay, that if you study inflammation very well, you won't have any problem in pathophysiology, and even pathophysiology may become boring, because when you study anything, even the newest research, the newest discovery, okay, is always related to some dysregulation of the inflammatory reaction. Sometimes acute, sometimes chronic, sometimes autoimmunity. There is a dysregulation of inflammation. Okay, so we need to understand, after we studied the normal body, okay, how this normal physiology may get deranged, okay, how homeostasis may be dysregulated, and how sometimes the body trying to adapt, okay, to the new conditions or to the abnormal conditions creates more problems. Remember when we studied physiology, for example, when we are under stress, when we are dehydrated, when we have low blood pressure, when we have any situation, there are several systems that work together to maintain, for example, the blood pressure or other variables. Okay, we have the cardiovascular system, the heart. If the blood pressure drops, it will beat faster, more strongly. The blood vessels will constrict. The kidneys are going to respond by producing renin, then angiotensin, aldosterone, etc. We have the endocrine system, the kidneys, we have the heart. The entire body is going to be working to try to maintain blood pressure. If one of these systems fail, for example, the kidneys are not doing their job, the other systems have to work more. Okay, imagine we are in a factory, we are 10 workers, 2 of them don't come to work, we have to work more that day. Okay, we maybe do more hours, another shift, etc. And that creates stress, that creates tension, emotional, physical. The same thing happens with the body. If this happens one day, that's not a big deal. Okay, that it's not a problem that the heart has to work more one day. But if this is happening every day, okay, during many years, and we need to understand, for example, when we consider the blood pressure, let's say you have a patient that is 25 years old, and they have a blood pressure. Normally, you tell them to measure the blood pressure. Normally, they have the blood pressure in 135/85. Okay, that is not bad. It's a little bit above normal. It's not very bad. I don't think we have to give any medication, no? But remember, this is a 25-year-old. And this guy is likely to live 60, 70 years more, 80, who knows? And this is a heart that is working against a little bit of more resistance than what is intended, that the original intention for the heart to work. That is below that level, below 120 and 80. Okay, this is exactly as if I give you a backpack with 5 pounds of weight. It's not too much, 5 pounds. What is that? And I tell you, you have to walk 10 miles. At the beginning, it's okay, but then, oh my goodness. I normally can walk 10 miles without too much fatigue, but now, after 1 mile, I'm feeling bad. Because that little extra weight is creating problems in the long term. The same thing happens with the heart, that is working against a little bit of high pressure for many years. This chronic exposure to a low level of stress creates problems in the future. Okay? Years from that moment. The same thing happens to our body. Sometimes cells get a damage, injury that is so bad, so intense, that they are destroyed. But sometimes they are exposed to tiny doses of toxins, stressors, excess hormones or deficiency of hormones, extra work, okay? And that creates a problem. So we are going to see how cells respond to injury, how they adapt or not. Sometimes they don't adapt and they die. What are the different mechanisms that can produce cell death? And here we have the beginning. Remember when we study physiology or pathophysiology, we have to consider things from at every level of organization. Okay, from the molecular, cellular, tissue, organ. Okay, here we have a normal cell that may be receiving any type of injury, chemical, thermal, electromagnetic, mechanical, toxins, different things. If the injury or the agent that is damaging the cell is not strong enough, they will develop some type of injury that is reversible. Okay? If this stimulus, this damage, this injury is removed, okay, these cells can turn to normal. Okay, but if this stimulus is very strong or extends for a very long time, cells may die. Okay, and they develop what is called irreversible injury. Can be manifested by different types of cell death. Okay, necrosis or apoptosis, depending on the situation. Okay, notice the characteristics of the reversible cell injury. You simply have like a cell that is changing the shape. It's like swollen, has some blebs. Notice the membrane has some blebbing, swelling of the endoplasmic reticulum, ribosomes detached from the endoplasmic reticulum. Notice that the chromatin, the nucleus, the DNA is like forming like clusters, clumping of the chromatin. That is reversible. If we remove the stimulus, and the cell may reorganize and go back to normal. Or simply, for example, when the mitochondria are affected and the cell stops producing ATP, we are going to have these irreversible changes also because of the rupture of the lysosomes that start releasing some enzymes that are proteolytic, lipolytic, starts destroying all the organelles of the cells. Okay, now you have in the irreversible injury, the rupture of the cell membrane, so all the contents of the cell are going to spread into the extracellular compartment. And for example, imagine that this is a cardiac cell. Normally cardiac cells have enzymes that work inside the heart, or different proteins that should be inside the heart cells, not in the blood. Troponin, for example, or different transaminases. Okay, when the cells are destroyed, the cell membrane is broken, and these enzymes go to the extracellular fluid and to the blood, is when we detect those enzymes, those proteins elevated in the blood. Okay, so when you have a patient with elevated troponin or elevated transaminases or different markers, you can determine where is the injury. It's in the liver, it's in the heart, it's in the skeletal muscle, it's in the pancreas. Find the pancreatic enzymes, the liver enzymes, cardiac enzymes elevated, and that is a sign of necrosis of the cells. That's why, for example, when you have a patient with chest pain and you don't detect elevated troponin, you say, well, this is angina. Okay, there is no necrosis in the heart yet. The patient has to rest, we give treatment, oxygen, aspirate, whatever we have to give to the patient. But the heart is okay. There is no necrosis. It's going to return back to normal, hopefully. But when we detect elevated troponin, cardiac enzymes, then that is a sign of necrosis. We know that there is a part of the heart tissue that has died. And that little part that died is going to leave then a scar, which is collagen, fibrous tissue, that then will impair the conduction system of the heart. Now the electricity doesn't travel through the scar. And we are going to see manifestations in the EKG, like a block of the conduction, like any abnormalities, or this scar tissue may start producing some action potentials, ectopic action potentials, and we may see atrial fibrillation or other types of arrhythmias, depending on what or where the lesion is, what is the extent of the lesion. But normally cells don't die initially, okay, when they are exposed to a low level of stressors or short duration stressors, and they simply adapt. For example, if the muscle cells have to work too much because we go to the gym every day to do push-ups for 2 hours, okay, the cells will adapt to this new workload, and they will respond with hypertrophy. Okay, cells may respond with different adaptations, hypertrophy, hyperplasia. Now we have to know what cells of the body are capable of dividing and what cells are not capable of dividing. Skeletal muscle cells don't divide, so they can only hypertrophy. But liver cells or maybe prostate cells, they divide. So they will respond with hypertrophy and hyperplasia, increasing the number of cells. Okay, neurons don't divide, so they are not going to have any hyperplasia. Okay, they normally don't increase in size. They typically shrink. That is what happens at the end of life. Our brain shrinks because of the atrophy of the neurons. Okay, so there is reversible, irreversible injury depending on the type, magnitude, duration of the stressful stimulus or the injury that cells are receiving. Now, causes of cell injury, there are many. You can make a list that is infinite. Okay, but we put there in bold letters a couple of them: hypoxia and ischemia. Okay, damage to the cells can be physical, chemical, thermal, infectious, okay, autoimmune, metabolic. Okay, there can be different things: lack of nutrients, excess of different substances, medications, or simply aging of the cells. All the cells have a programmed number of divisions that they can perform. Okay, once they reach that number of divisions, they simply stop dividing. Okay, and even if they divide, they may not work properly. Let me give you the example of the hippocampus, okay, where we process our memories. Okay, the hippocampus, we produce every day 100 or more neurons in the hippocampus to create new memories, to store more memory. Okay, the hippocampus and the olfactory epithelium are the only 2 areas of the brain that we know that produce new neurons. Even if you take a person with a 80-year-old, 90-year-old, they produce 100 neurons daily. How is possible that they have memory issues? Simply because these neurons are not receiving the proper blood supply because of the changes in the cardiovascular system, the low number of capillaries, okay, the problems with circulation, maybe atherosclerosis or other problems. So if these neurons don't receive blood, they are not going to process memories properly. Okay, so there have to be many different factors together, okay, for our body to work correctly. We are going to be focusing in this first presentation on hypoxia and ischemia, the effects of lack of oxygen or lack of blood supply, okay, to different organs, how this can damage the cells. And this is the general mechanism of cell injury. If cells are not getting oxygen, if they're not getting blood, remember, oxygen is essential, it's necessary for ATP production, at least aerobically. Okay, mitochondria need oxygen as an electron acceptor in order to produce ATP. So when the cells don't produce ATP, that will lead to a sequence of steps. First of all, ATP, sodium-potassium ATPase activity declines, cells don't produce ATP, and now the sodium-potassium pump doesn't have the fuel to take the sodium out of the cells and the potassium back. And what happens when sodium levels increase inside the cell? Now we have a greater concentration of sodium inside the cells, and remember osmosis. Water will start entering the cell, trying to balance the sodium concentration in and out of the cells. That leads to an increased content of water in the cells, so they start swelling. Sometimes swelling so much that you can see even blebs in the membrane, as we saw in the first picture. lack of ATP will produce a shift to the anaerobic respiration, to glycolysis, a process that only produces 2 ATP per glucose and also produces lactic acid. So now we have a drop in the intracellular pH because of the lactic acid accumulation. We have more water, more sodium, and more acid. Now, anaerobic glycolysis starts consuming the glycogen of the cells, so the energy reserves are going down at the same time that all this is happening. If we don't have ATP, the calcium pumps inside the cells are also going to be affected. Remember, cells contain calcium within the endoplasmic reticulum, smooth endoplasmic reticulum. Okay, and normally the cytoplasmic concentration of calcium is extremely low. We only release calcium when we need to activate an enzyme and then take it back. And that has to be against concentration using ATP, calcium ATPase. No ATP, calcium stays in the cytoplasm. And the enzymes that normally are activated by calcium will remain active. And those enzymes are lipases, proteases, endonucleases that break down the nucleic acids. So that starts breaking down the membranes of the endoplasmic reticulum, the lysosomes, mitochondria, Golgi, etc. And the proteins inside the cells. Okay, so also there is a reduced protein synthesis at the same time that this is happening. And finally, there is a mitochondrial damage. Okay, when we have this hypoxia, all these issues, okay, and we start having many chemical reactions occurring at the same time because of enzymes that are activated. We have many of these reactions that are oxidation reduction reactions that are occurring rapidly without control, and that will lead to the production of reactive oxygen species or free radicals. Okay, so the free radicals, intracellular calcium, the damage to the mitochondrial membrane that increases the permeability will finally destroy the mitochondria. And when we destroy the mitochondria, some mitochondrial enzymes like cytochrome C and other enzymes that are called caspases are going to be released to the cytoplasm, and those are signals for the cell to commit suicide, apoptosis. Okay, that is one of the ways that cells can die. Okay, or they simply can die by necrosis. The difference between apoptosis and necrosis is apoptosis is organized. There are steps that we pack. When we are moving, we put everything in boxes, and we hire someone, or we do it ourselves, put the boxes in a truck and move and clean the house and paint the house. We don't want to lose the deposit. Okay, but everything is fine. Now, if we are evicted, some people come very hostile and they put all of our belongings on the street. That is the difference between apoptosis, organized, cell dead, moving nicely, or necrosis, eviction, in which we put all the contents of the cells in the extracellular fluid. Then there are many neutrophils, inflammatory reaction, and there is a mess. Okay? Now we are going to be covering the different cellular adaptations that you probably have studied in the past. But we're going to see some examples and have clear the definitions. Hyperplasia is simply an increase in the number of cells. Plasia means growth. Hypergrowth. And of course, if we have an increase in the number of cells, the organ is going to increase in size. Okay? There are some physiologic and pathologic causes of hyperplasia. For example, during pregnancy, okay, there is hyperplasia of the breasts, endometrium in pregnancy and also in the menstrual cycle. Okay, those are normal causes. The liver, okay, if we damage the liver, we cut part of the liver is able to regenerate up to 70% of the original mass. But then we have pathologic causes. For example, if we have excess hormone, excess ACTH, the adrenal cortex is going to get hyperplasia. we have excess dihydrotestosterone, the prostate is going to undergo hyperplasia, producing many urinary symptoms. There are different tissues that, if they have a prolonged stimulation of hormones or growth factors, they are going to have hyperplasia. Okay, only cells that divide, okay, may undergo hyperplasia. Hypertrophy, okay, is increasing the size of the cells without the increasing number. Okay, can be physiological, like the exercise example we mentioned, or pathologic, when there is an abnormal stressor, for example. Normally the cardiac cells don't divide either. Okay, the heart, the only thing that can happen to those cells if the heart works too much is the increase in size. Okay, people may develop hypertrophy of the myocardium. Okay, the heart doesn't have too much room to grow outwards, so the only thing the walls can do is grow inwards, reducing the size of the cavity of the ventricles, leading to a reduced amount of blood that the heart can receive. The end diastolic volume, the preload, is decreased when we shrink the cardiac cavities. Okay, now hyperplasia, hypertrophy, both, remember, can produce organ size increase. Okay, when we see an organ, let's say you see a big thyroid, there could be hypertrophy or hyperplasia or both. We don't know with the gross examination. Okay, we have to do a microscopic examination to see. Okay, so that is the pathologist, the one who's going to tell us hypertrophy, hyperplasia, dysplasia, other types of changes that we are going to be seeing. So there can be many causes for hyperplasia and hypertrophy. Remember the example of excessive stimulation by hormones? Okay, but also, even without the increase in the levels of a hormone or growth factor, sometimes cells may increase the number of receptors. So they are stimulated by more amount of the hormone. That can be a cause. Okay, or there can be what we call induction of protein synthesis, production of more proteins that make the cells grow. Okay, these processes may occur together or independently. These proteins that can be increased production can be transcription factors, so there is more transcription of the DNA to produce more proteins, or different contractile proteins like actin, myosin, or some embryonic proteins. Now, the contrary of hypertrophy is atrophy, which is a decrease in the size of the cell that was normal before. Okay? There are physiological causes, for example, the decrease in the size of breast and uterus during after pregnancy or during the menstrual cycle at the end, or pathologic, when there is a lack of stimulation, no growth factors, no hormones, no blood supply, no innervation. We have, for example, a lesion in a peripheral nerve. Now the nerve is not stimulating the muscle, so to maintain a muscle tone, the muscle will atrophy. Okay, or when we have a cast for a long time, maybe you have experience, you remove the cast, the limb is thinner than the other one. Okay, decreased workload. Someone who is bedridden for a long time, okay, if they don't do physiotherapy, even doing physiotherapy, sometimes it's difficult to maintain the muscle mass. People who go to the space, stay for some time there, the lack of gravity, okay, also produces muscle atrophy. That's why they have to work out when they are up there. And aging, okay, aging, even if we exercise, of course, exercising is great, we delay, okay, this atrophy of the muscles, but there is a moment that even if we work out, okay, as a result of the age of the cells, they are unable to produce the same amount of proteins. Okay, so inevitably at the end of life, everything takes its course. Now, that is a note, have it clear. Remember, atrophy is a decreasing size of a cell that was normal. Okay, there are other conditions. For example, if an organ doesn't develop at all, baby is born and they have a very small organ, certain organ, maybe the thymus or maybe other organ, that is called hypoplasia. Okay, this is an organ that is small but was never normal. It's congenital. Now, here we are moving to more disorganized forms of cellular adaptations. The previous ones, for example, when you have an organ with hyperplasia, it has more cells, but the cells are identical to the normal ones. There is no difference. Okay, in hypertrophy, the only difference is the size, but they look perfectly fine. Larger, but fine. Now here we have metaplasia. This is the change of one type of cell into another. Okay, for example, when you study histology, when you study tissues, you know that different organs have a different type of epithelial tissue and connective tissue. Let me give you the example of the esophagus. The esophagus has stratified squamous epithelium, many layers of flat cells, very good for protecting the tissues against friction, against hot drinks, etc. Okay, but if we expose the esophagus to something that the esophagus is not prepared to endure, to stand, those cells are going to react. Okay, when people have gastroesophageal reflux, the chronic exposure to acid of the lower third of the esophagus, that burning injury, okay, will stimulate stem cells, and those stem cells are going to grow not as squamous cells, but they are going to be different cells. For example, columnar cells, taller cells. Okay, to increase the distance, okay, between the inner part of the body and the acid. That is called metaplasia, the change of one type of epithelium into another. Now, if you look at that transformation, the squamous cells look normal squamous cells, columnar cells, like the ones we have in the intestines. But they are in the wrong place. We call it metaplasia. Columnar epithelium in the esophagus is one example. That is called Barrett's esophagus. Also known as intestinal metaplasia, because the epithelium of the esophagus is changed in one that looks like the one of the intestine. Columnar cells with many cells that produce mucus, which are called goblet cells. The squamous, glandular, contains these unicellular glands that are the goblet cells producing mucus as a way of protecting the esophagus against the action of acid. Also may happen in the lung. Normally in the airways, in the bronchi, we have this pseudo-stratified ciliated epithelium. But if we smoke, okay, the cells of the bronchi will react to that. And we'll try to create an epithelium that protects the lungs against the effect of tobacco and toxins. So in the lungs, we are going to develop a stratified squamous epithelium instead of the columnar ciliated. That is called squamous metaplasia. That if progresses, may lead to the formation of squamous cell carcinoma of the lung. Okay, so this is a starting point to understand what happens in the body as a result of this chronic exposure to toxins. And as I was telling you at the beginning, if someone smokes a cigarette, they're not going to die. Okay, the injury is not enough to kill a person. But if we are exposed chronically to this low level of toxins, our body is going to react with different adaptations that will be increasing in severity until something goes wrong. Here we have examples of the things we mentioned. Okay, here we have the example of Barrett esophagus, an example of metaplasia. Okay, initially the cells resemble small intestine cells and then colonic lining. So at the beginning there is a change of the squamous cells to columnar cells, but then we have the cells, the addition of the cells that produce mucus, the goblet cells. So ends up being like the colon. From squamous to columnar with goblet cells. Okay, here we have the histopathology of this condition, Barrett's esophagus. There you have the normal epithelium of the esophagus. Intestinalized epithelium, notice the change from squamous to columnar. And here, all these clear spaces are the goblet cells, unicellular glands that produce mucus. Now, these are forms of cell death. Okay, if cells continue receiving stimulus and at the same time they have a lack of blood supply, or if the stimulus is so high in magnitude, it destroys the cells, cells may die by different means. Okay, we already mentioned apoptosis. Notice that I say apoptosis and not apoptosis. Okay, it's like palpebral ptosis. Okay, you write P-T-O, you say ptosis, not ptosis. You don't say psychiatry. Okay, it's apoptosis. It's a control program cell death, okay, in response typically to DNA damage. Normally when cells divide, okay, first they have to replicate the DNA. There is a great enzyme that makes a perfect copy of the DNA polymerase. Mind how perfect that enzyme is, that it copies the DNA and then goes back to make sure everything is fine. Has a proofreading activity. If there is any mistake, it stops, calls for help, other enzymes come, cut, and put the other nucleotide, and it continues. Okay, but sometimes mistakes happen, and sometimes the DNA polymerase doesn't detect the mistake. We have other mechanisms to detect that mistake. We have genes, okay, that will stop the cell cycle to see if they can repair the DNA or not. If the DNA is repaired, okay. If not, the cell will die by apoptosis. Okay, other examples of apoptosis is the development of the T cells in the thymus. Okay, T cells are made in the bone marrow, they go to the thymus, and they have to pass through 2 levels of education. Okay, academic year, clinical year. Okay, they need to demonstrate that they are good at interacting with other cells, that they recognize, differentiate our cells from foreign cells, and that is an amazing process. And once they demonstrate that they know how to recognize and differentiate self from non-self, they go to another step in which they are tested to see how strongly they interact with our cells. Too weakly, too strongly, and the cells that don't pass the 2 levels are simply gonna undergo apoptosis. Okay, there is like a cemetery there with all the dead T cells that couldn't pass the tests. Now, necrosis is uncontrolled breakdown of cells. The most important difference to remember between apoptosis and necrosis is necrosis produces inflammation. Apoptosis is like no one notices. One day you wake up in your house, where are these neighbors? Oh, they moved yesterday. Oh my goodness, they didn't say anything. But if someone is evicted, you will notice. The police, this and that, and sometimes the press. There are different types of necrosis, and they occur different organs depending on the characteristics of the organs. Some organs, for example, the brain is made mostly of fat. Myelin is fat. Okay, the heart is made of meat, muscle. Okay, so they are different in consistency. Some of them have a more organized connective tissue structure. The architecture is more solid. Some of them have a less organized connective tissue structure. Okay, so they are gonna have necrosis in different ways. One of them is called liquefactive. Liquefactive necrosis, liquid, something that gets liquid, typically occurs in soft organs that don't have this solid matrix of connective tissue, like the brain, okay, or the pancreas that have many enzymes, organs that are soft. Pancreas means flesh is soft, and it doesn't have any capsule. So the brain, the pancreas, are gonna have this liquefactive necrosis. They become liquid when they have necrosis. Okay, now this destroys cells, proteins around. Okay, there's a lot of protein breakdown, and the tissue, if you look at it, after a person has a brain infarction, for example, or a pancreatitis, you're going to see very soft material. Now, the other type of necrosis is coagulative. This is like forming a clot. It's more solid, it's not liquid. This occurs in solid organs. So these organs typically preserve their shape because there are some coagulation proteins that keep the structure of the organ in place. Of course, the tissue changes because of the necrosis, but the shape of the organ is not altered. There is a lot of protein denaturation, more than enzymatic breakdown. This is the most common type of necrosis, the coagulative. Can occur in the heart, liver, kidney, solid organs. In the brain occurs immediately after the lack of blood supply, but then when we start the enzymatic breakdown and because of the lack of solid matrix, all that tissue is going to get very soft. So moving from a very short period of coagulative to a liquefactive necrosis. And then we have fat necrosis that occurs mainly in the adipose tissue. And the classic example is what happens when people develop pancreatitis and the pancreatic enzymes, remember the pancreas doesn't have a capsule, the pancreatic enzymes move to the abdominal cavity, destroying all the abdominal fat. Okay, that is fat necrosis. One characteristic of the fat necrosis is that it will develop, okay, if this becomes a chronic issue, will develop what we call saponification because of the combination of this fat with calcium. For example, in a patient with an acute pancreatitis, when you make an abdominal X-ray, you may not see anything. But in a person with a chronic pancreatitis or a person who has had many attacks of acute pancreatitis, we may see like calcifications in the area around the pancreas because of the accumulation of calcium in the area of fat necrosis. Then we have caseous necrosis. That caseous means cheesy, because when you open the tissue, it looks like cheese. Cheesy looking necrosis that typically is associated with tuberculosis. Okay, something that when we say caseous necrosis, for us, that means mainly tuberculosis. Another type is fibrinoid. It's a necrotic tissue that contains, as the name says, a lot of fibrin, this protein from the blood, from fibrinogen. Okay, this is from the leakage of fibrin from the blood, not from the blood.
Like 30 seconds. Everybody, can you guys listen up over here, please? Thank you. So I just wanted to announce that Brain Bowl is going to be either Mondays or Wednesdays starting next week. Professor Concepcion is going to let us know. If anybody wants to be added to the Brain Bowl chat, you could just come up to me and I'll be happy to add you guys.
Thank you.
Thank you. 5 to 7, sorry. 5 to 7, yeah. Hi.
So, clinically speaking, okay, because when we say apoptosis, necrosis, when we talk about all these topics, okay, we are talking about something that is typically identified by people who look at tissues under the microscope or using different mechanisms. Okay, when we are talking with clinicians and we have a patient, we typically don't say necrosis. No? I have a patient with necrosis of the myocardium. We typically don't say that. We typically say infarction. Okay, but the clinical term for necrosis is infarction. Okay, and there are different types of infarcts. Okay, some infarcts, depending on the characteristics, when you look at the organs, are classified as red or pale. Okay, red infarcts are also called hemorrhagic. Okay, and this occurs when there is a re-entry of blood. Okay, the tissue dies as a result of a lack of blood supply, but then blood may enter again. Okay, following cell death. This tissue is going to look red and happens, for example, in tissues that have collateral blood vessels, collateral circulation or double blood supply. Okay, like the liver, for example, the lungs. We are going to see a red area of necrosis. Intestines. Or, for example, even we break an embolus. The patient has an embolism, cut the blood supply, we use thrombolytics to break the embolus and then blood enters again. That area is going to look red. Now, pale infarctions is when blood doesn't enter, okay, in the area that has died. Okay, tissues that don't have a double blood supply. For example, kidney, heart, spleen. Okay, or for example, when we can't break the thrombus or the embolus, okay, and we try to break it, but we don't get it. There is a continuous formation of clots at the site of the obstruction. Here you have the appearance, for example, in the small intestines, red, in the lung, and this is in the kidney. In the case of the heart, it's going to look the same pale area, scar tissue. Now, another important thing to have in mind as part of the cell injury process is the cellular accumulations. Okay, when cells don't work properly because of lack of energy, because of not having ATP, or because of being too busy doing other stuff, they start leaving some tasks to do. Okay, mind you have daily tasks to do at home. You have to wash the dishes, you have to clean this, clean that, but then you have a problem in the garden or something's going on, and you can't pay attention to that. Maybe you have to visit someone for a week, and your house is going to have accumulations of dirt and stuff that you have to take care of. Same thing happens with our cells. The liver is an organ, for example, that works a lot, doing many things at the same time. Okay, there are different areas that do different things, but they work a lot. If now we start giving extra work to the liver, like drinking alcohol daily, okay, 3 drinks per day, for example, now the liver is going to have to work detoxifying the alcohol, and maybe it can't work doing the things that it normally does, like fat metabolism. So if I have to process dietary fat, and take this there, make this, etc., but now I have to work with alcohol, I can't pay attention to the fat. I have to, okay, a little bit of alcohol, a little bit of fat, but there is a moment when I'm going to have a lot of to-do things here. And that's the origin of what we call the fatty liver. Okay, when you have accumulation of fat inside the liver cells, you can see even the bubbles of fat, the little droplets. Another accumulation is what we call lipofuscin. Okay, it's a product of the peroxidation of the lipids. Okay, it may accumulate in the cells, for example, as the cell ages, in the lysosomes. Okay, and this is the spots that we see in the older people. Okay, these brown spots that people may have in the skin, in the face, in the arms, everywhere. Okay, that the correct name is lipofuscin-laden lysosomes, lipofuscin accumulation. Popularly, they are known as brown atrophy. Okay, and I remember when I was a kid, and I asked someone very old, "Why you have those many spots?" He told me, "These are the flowers of the cemetery." Wow. That was impacting, no? Now I know it's liposuction, not flowers.
Are those the same brown spots on the face?
But there are other types of brown spots, for example, after pregnancy, that you can have a chloasma, or sometimes we have, for example, acne lesions that we manipulate and get infected, may leave a brown spot sometimes for 2-3 years, or other things as a result of a sun. Okay, we are talking about the lipofuscin degeneration that appears, spread.
It's more widespread.
Also, you said brown atrophy, but more commonly known liver spots. What they call? What a lot of
Liver
people say liver
spots.
That's what they call them, no?
They call them liver spots.
Like
I know
it's very
what I know
very
as
late
liver
term.
spots is the reddish marks on the abdomen.
No.
These are called liver spots.
The ones in the hands.
Yeah, a lot. Like the old people say, oh, I'm covered in liver spots.
Well, in Spain they call liver spot to the reddish nevi that appear on the skin. Okay. Every time you have this reddish nevi on the skin, they say this person drinks a lot. That's the liver.
Like the cherry.
Like the cherry angiomas. Now, calcium accumulations. Okay, remember calcium we mentioned before, every time you have a fat necrosis, calcium will go there. Okay, that is a very important concept to keep in mind. When someone has an acute pancreatitis and they start having fat necrosis, okay, many of the calcium that we have in the blood will bind to that fat. And people may develop hypocalcemia as a result of this necrosis of fat in the pancreatitis. So it's a potential complication of pancreatitis. Accumulations can be classified as metastatic or dystrophic. For example, someone who has hypercalcemia, let's say a patient with hyperparathyroidism. They have elevated calcium levels. That calcium doesn't have anywhere to go, may get deposited in the tissues. For example, in the endothelial cells or different tissues. Or dystrophic, that occurs in patients with normal calcium levels, okay, but may have this accumulation of calcium within necrotic tissue, like the example of the pancreatitis that I told you that you can even see in the abdominal X-ray, the calcifications. You may see it in the blood vessels, in the kidneys, in the lungs, in the brain. Different places may get these calcifications. Notice that this metastatic has nothing to do with cancer, okay? It's simply the name it receives. Now, other accumulations, and here we have some terminology that is important to have clear the difference, because sometimes we confuse words that sound similar. Okay, there is one that is called hemosiderosis. Hemo, blood, siderosis. It's accumulation of iron in organs with no clinical effects. Okay, for example, every time we have a bruising, we are going to have some blood cells in between the tissues. Those blood cells are going to be destroyed. You're going to have the hemoglobin being processed. You have changes in color from blue to green, yellowish, etc. Those are processes of the metabolism of hemoglobin. And we may have iron accumulation there for a while, and then it goes away. Okay, but sometimes the iron may stay within macrophages. Maybe resident macrophages may take the iron, and we may have some little spots there as a result of the iron. This can be larger or smaller. Has no clinical effects. Now, hemochromatosis is when we have accumulation of iron in parenchymal cells. What is a parenchymal cell? Is the cell of the tissue that performs the function of that tissue. Okay, if you take a tissue, an organ, for example, let's say the thyroid or the liver, the cells of the liver, the hepatocytes, are the parenchymal cells of the liver. Now, all the rest of the tissue of the liver, the blood vessels, nerves, the connective tissue, all these structures are called the stroma, the supporting structure of the architecture of the tissue. So when the iron accumulates in the parenchymal cells, people develop liver or heart or any organ dysfunction because now inside the liver cell we have excess iron that shouldn't be there, and that will change the properties of the cell. It's going to impair the working of many things. So may lead to congestive heart failure, diabetes if it happens in the pancreas, may happen in or may produce cirrhosis of the liver. Another accumulation is fat. We mentioned the example of the liver working with alcohol or with medications. Now it can process the fat. Another term for this fat accumulation is steatosis, liver steatosis. Okay, that term is going to appear very frequently. For example, fatty diarrhea is called steatorrhea. Liver steatosis is accumulation of fat in the liver. Okay, this fatty liver may indicate reversible damage or may be a sign of something that is irreversible, like a cirrhosis of the liver. We're going to be seeing this when we move to gastrointestinal tract. Cholesterol may accumulate too. Okay, sometimes we see people that have some yellowish spots on the skin. Okay, that may be around the eyes or maybe in the elbows or in some places. Okay, or maybe in the blood vessels, for example, atherosclerosis. This cholesterol is inside the macrophages. Okay, macrophages eat, phagocytose the cholesterol, and then they have enough cholesterol inside, they grow, and you can see them from outside, like in the skin, we can see the yellowish lesions. Another accumulation can be glycogen. Okay, that typically happens as a result of some congenital metabolic disorders. Okay, that is not very frequent unless you have a patient with this specific disorder. Okay, glycogen storage disorders that if you have to study, it's like to become crazy of the different types that there are, signs and manifestations. Okay, this affects the liver and skeletal muscle. Proteins may accumulate, for example, in Alzheimer's disease. Okay, there are all of these plaques of amyloid that we have around the neurons in Alzheimer's and other types of dementias as well. They receive different names. We have Parkinson for frontotemporal dementia, different proteins that accumulate. And then we have pigments, exogenous or endogenous. For example, tattoos are exogenous pigments that accumulate in the macrophages of the skin. Okay. Also, what we call anthracotic pigment. Okay, debris from carbon. Okay, from pollution or cigarette smoking. If you see the lungs of a smoker, maybe when you went to the morgue, if you had the opportunity of seeing a smoker, you can see the lungs are totally black because of the smoking. That is anthracotic pigment. And endogenous can be melanin or can be bilirubin, producing nevi, producing different spots on the skin, or simply lack of melanin will produce vitiligo or different other conditions, and bilirubin producing jaundice. They're just examples of accumulations. So that was the section of cell injury and adaptation. Okay, simply have very clear the different concepts, examples of types of necrosis and different types of adaptations, etc. So now we can move to inflammation. Okay, inflammatory reactions. I remember it's the center of pathophysiology. Okay, so study this very well. So, it's a ghost. And well, inflammation is part of the defense system of the body. Remember, our defenses, when you study immunity, are divided into innate and adaptive immunity. Inflammation is part of the innate immunity. But everything is linked. Okay? It's impossible to study one part of the immune system without the other, because the inflammatory reaction, okay, typically tries to, it says there, recognize, detect, isolate the agent that is trying to damage the body, tries to remove it, but also recruits inflammatory cells. Some of these inflammatory cells belong to the innate immunity, non-specific immune responses, but other cells belong to the adaptive response, lymphocytes, for example. Okay, this purpose of inflammation is also try to regenerate, repair the tissue that has been damaged, or limit the amount of tissue that can be damaged. Okay, inflammation is a normal process of the body, but sometimes gets out of control. It may be too weak or too strong, or may be directed against the wrong target, like when we have autoimmune reactions. Okay, it's a process that we typically see as pathologic, but it's a normal defense mechanism that is necessary for survival, and can be classified in acute or chronic, as many other things in medicine. In the past, there were a lot of definitions. Acute inflammation, less than 3 months. Chronic, more than 3 months. Acute pain is less than 3 weeks. Chronic pain. These things are totally arbitrary. Okay, acute inflammation is going to be acute depending on what is the agent that is causing the inflammation. If I hit my hand against something, I am supposed to have acute inflammation for some hours. But if I have hepatitis A, I am supposed to have acute inflammation for some months. No? So we prefer to say acute or chronic depending on the specific time expected for normal healing of the tissue, depending on the condition that is affecting the tissue. Okay? If I go to the beach and I'm exposed to sunlight and have burns in my back, and 2 months later I still have that injury, should I wait 3 months to say this is chronic? It was supposed to be healed like more than 6 weeks ago. Okay? So we have to look at the expected time for healing. Same for pain, same for any symptom sign. So inflammation has different phases, there are different types. Okay, we are going to be talking now about the acute inflammatory response. Okay, it's the immediate response that occurs after any kind of injury. Has limited specificity, that means it's the same response no matter what is the agent that is causing the damage, and can be triggered by different stimuli, infections, tissue damage, different types of agents that damage the body. Okay, and should be very, very well controlled. Okay, to protect the body against the infection, and at the same time not damage the body. Okay, many of the diseases that we are going to study, okay, are due not to the agent that is infecting the body, but due to an exaggerated overreaction of the immune system. For example, cases of hepatitis. If you take a culture of human cells in a petri dish and you put there hepatitis B, you can have that culture there with nutrients 10 years, 20 years, and you don't see anything wrong. Now you put some lymphocytes there, oh my goodness. The war will start. And it's the war what destroys the liver, not the hepatitis virus. Okay? It's like, for example, herpes virus. We get a herpes infection when we are 10 years old. That virus is going to live in our sensory ganglia for many years. And we won't even realize unless we have this once in a while, these problems as a result of what they call cold sores. Okay? But the virus is there always and nobody notices, nobody remembers. Okay? Viruses are so tiny that they are not going to produce anything. The cells may not even notice that the virus is moving around. Now, if the lymphocytes detect the virus, that's when the problem begins. Okay? And if not regulated, okay, the entire body may suffer severe things as a septic shock. Okay? And there are different pathways, okay, after the inflammatory response is triggered. There are several steps, several events, okay, that involve different proteins, different cells. There are inducers of the inflammation, there are sensors, there are mediators, there are effectors of the inflammatory response. And we call acute inflammation typically to the inflammation that lasts for a short time, depending, remember, of the expected time depending on the injury, and has these 4 cardinal signs, or 5, if we add the loss of function. Okay, the classical signs of inflammation were the first 4: rubor or redness, dolor or pain, calor or heat, tumor or swelling. And we need to understand why these signs occur. What is the reason for them? Okay, for example, redness occurs because of the dilation, the dilatation of the blood vessels locally after the injury. There are some inflammatory mediators that will trigger that. For example, prostaglandins. Where prostaglandins come from? Okay, where do we have any storage for prostaglandins in the body? Okay, are there any cells that have granules with prostaglandins to release? No. When there is a tissue damage, many cells are going to suffer. Immediately they are going to be destroyed. Remember, the cell membranes contain phospholipids. Once the cell injury occurs, there's going to be one enzyme that is called phospholipase that is going to be activated. It's going to break down the phospholipids to form arachidonic acid. Arachidonic acid is going to follow several metabolic pathways. One of them is the formation of prostaglandins. There are different types of prostaglandins, or may take the pathway of the formation of leukotrienes, depending on what is the nature of the damage. And the reason why we take ibuprofen, aspirin, etc., is to block the formation of prostaglandins and reduce the inflammatory response. Okay? If we take corticosteroids, for example, we are going to block not the prostaglandins, but the phospholipase, the initial enzyme. But we are going to block the entire inflammatory response. That's something that you need to get, that you will get in pharmacology to understand the why. We use different medications in different situations. What are the possible side effects? Okay, not only prostaglandins, also bradykinin. Okay, the bradykinin system is a system that we typically don't teach in physiology, but is related to inflammation and also to the production of chemicals that produce pain, stimulates pain receptors. Prostaglandins 2 stimulate pain receptors, and histamine also stimulates pain receptors and also may produce itching. Okay, histamine is the most powerful vasodilator that we have in the body. Okay, it's a very powerful vasodilator. It will not only produce vasodilation, it's also going to trigger the separation of the endothelial cells. Endothelial cells typically are very tightly joined with tight junctions. Histamine will make them separate. And we need that separation because if there is any potential infection, we need neutrophils to go there to attack the infection. Then we have pain, okay, from the stimulation of the pain receptors. Pain receptors are free nerve endings. There are different types. Okay, we have the A delta fibers that transmit the sharp pain immediately after the injury. And we have the C fibers that are unmyelinated and very thin and transmit this dull pain that is poorly localized. There are interesting things about these different types of pain fibers. For example, when you have this sharp pain, A delta fibers, first pain, that goes directly to the somatosensory cortex and tells us there is something wrong, we have to go away from here. Okay, withdraw your arm, your leg. But then we have the secondary pain, or second pain, slow pain, transmitted by the C fibers, very slow, poorly localized. That doesn't go to the somatosensory cortex, that goes to the limbic system and makes us feel, oh my goodness, I feel so bad. Okay? That's more our emotions and creates a memory of, do not touch that because that hurts. That happens for physical pain and emotional pain as well. Do not call that person anymore because it will hurt you. And we call, how are you? Ghosting. And there is a secret that no one knows. In the same way, you know that there are some anti-inflammatory medications that act peripherally, ibuprofen, blocking prostaglandins. But there are other analgesics that act centrally, in the pain centers. Acetaminophen. Acetaminophen works inhibiting pain signals within the brain. Pain is here, it's not here. Acetaminophen is good not only for physical pain, also for emotional pain. Because the same place that processes physical pain is the one that processes emotional pain. Okay, so acetaminophen, Tylenol is good. Okay.
Somebody breaks their heart, pop a couple of Tylenol, will calm down a little bit.
The emotional pain too. Now we have calor or heat. Notice that the heat also appears as a result of the vasodilation. Now we have more blood. So the skin not only looks red, now it's warmer. And the mediators are the same, prostaglandins, bradykinin, okay, and histamine. Swelling or tumor occurs as a result of the increased vascular permeability. Remember, histamine opens up spaces between the endothelial cells that will allow water, fibrin, antibodies to go to the site of injury. Okay, that increased amount of water, okay, will produce the swelling of the tissue. Okay, that is a type of fluid that we call an exudate. We're going to see later the difference between two types of fluids that can move to the extracellular compartment. Okay, one is the exudate that has to do with inflammation, and the other is the transudate that has to do with other factors. We're going to see that later. And the fifth cardinal sign of inflammation that was added years later to the four cardinal ones is functiolaesa, or loss of function. That may have different reasons. Okay, pain may simply be so strong that you can't move the joint or the arm or the limb, or maybe because of damage to nerves, okay, or the edema that will limit the range of motion, okay, or compression of the blood vessels, etc. Different causes. Well, here we have the pathogenesis of inflammation, the different stages. We can divide the acute inflammatory response into two phases: a vascular phase and a cellular phase. Okay, the vascular phase, we already mentioned why it happens. There is an injury to the tissues start releasing prostaglandins, bradykinin, histamine from the mast cells. All these cells produce inflammatory mediators. And now we have the activation of the endothelial cells that will shrink, and the blood vessel will dilate. Okay, the shrinkage of these endothelial cells increases the separation between them, okay, allowing all this fluid to leak out. So there is vasodilation, there is increased capillary permeability with exudation of fluid. Notice that an exudate is a fluid that is rich in antibodies and proteins. A transudate, on the other hand, the one that we are going to see later, is a fluid that is just fluid, like the plasma. Okay, it doesn't have too many proteins or antibodies. Why not? Because there is no separation between the endothelial cells, okay, when we have this excess fluid as a result of a transudate. What is the best example? When the heart fails. When the heart fails, there is an increase in the pressure in the pulmonary circulation, and fluid leaks into the lung tissue, producing lung edema. But that fluid is just fluid. It doesn't have too many proteins or antibodies. It's as a result of increased hydrostatic pressure, not as a result of inflammation or increased vascular permeability. Okay, now we have this very necessary fluid with antibodies and fibrin, etc. And then we have the cellular phase. Remember, histamine will produce the contraction of the endothelial cells, and they separate. These cells of the endothelium, once they are activated, start expressing some proteins in the cytoplasm, in the cell membrane, that act like a Velcro for inflammatory cells. Okay, now these adhesion molecules are gonna activate lymphocytes, are gonna make the lymphocytes or neutrophils first to enter inside the tissue that has been damaged, leukocyte activation, emigration, okay, that will move through chemotaxis to the place of infection, following the concentration of inflammatory mediators. That's how they go where to go. Okay, they follow where are more inflammatory mediators in that direction, and they move there. They will produce phagocytosis. Neutrophils have granules with many enzymes, like reactive oxygen species, proteolytic enzymes that will destroy, okay, the pathogens. Neutrophils, once they act, they die immediately. And then all the DNA of the neutrophils is spread, okay, and will form like a mesh that will try to isolate the pathogen. It's a very important function of the neutrophils. Okay, that DNA of the neutrophils plus the fibrin will try to isolate the pathogens. Okay, forming like a barrier around the pathogens if they are there. So what is the importance of all that? Well, notice that exudation helps deliver plasma proteins like antibodies. Also, that increased water dilutes toxins, and that increase in the hydrostatic pressure in the interstitial fluid will increase the lymphatic drainage. Now this excess fluid will move through the lymphatics, taking pathogens, debris, okay, inflammatory cells towards the lymphatic nodes. And we need there to activate the lymphocytes. Neutrophils help remove, isolate pathogens, remove debris. Vasodilation increases the delivery of cells and proteins. When you have this vasodilation, the blood circulates more slowly, giving time for the movement of inflammatory cells towards the place of infection. And pain, loss of function, help us not use that joint or not use that part of the body, okay, to give time to the repair of the body. There is more to this because we are not mentioning the effect that all these cytokines or cytokines that we produce as a result of the inflammation has on the brain. Okay, the brain is also receiving signals that something is wrong in some part of the body, and that makes us feel bad about that and not go out and sit still and wait for the repair to occur, and not exercise and not do crazy things. So we have here more details about this pathogenesis of inflammation. Okay, we have the role of the endothelium. Endothelium, when I studied medicine, was like a lining for the blood vessels. That is called endothelium in the blood vessels and endocardium in the heart. That was the endothelium. Like a smooth pathway with tiles, shiny. Nowadays, if you start studying only the endothelium, you can spend 20 years studying endothelium because every organ has a different type of endothelial cell with different functions, different markers. Endothelial cells are the ones who signal stem cells to become this or that. And even there is a theory, I haven't read that for sure, that there is any proof of that, that endothelial cells in some cases may become stem cells in the organ where they are. I'm not totally sure, don't believe that yet. But generally speaking, the endothelium is a selectively permeable barrier. There are different types of endothelial cells. Some of them are more tightly joined, continuous endothelium, and even totally impermeable, like in the blood-brain barrier. There are other endothelial cells that are more loose, okay, having separations, like the sinusoids of the liver, spleen, thymus. And there are fenestrated endothelia, like in the kidneys, for example, will allow certain things to move depending on the organ. Okay, it's a very good barrier that typically maintains the blood vessels open, unobstructed, preventing the binding of platelets or other cells. Okay, it's anti-thrombogenic, prevents inflammation, simply keeps the neutrophils away. You say anti-inflammatory. And if there is any dysfunction of the endothelium, that's when the problem starts for different organs. The dysfunction of the endothelium may start if there is a damage, physical damage, or if there is a viral infection that affects the endothelial cells, or as a result of exposure to toxins, to free radicals, to different things. Okay, and when there is an injury to the endothelial cells, the inflammatory mediators, the free radicals, will activate the endothelium, producing different types of conditions. Look at this diagram where we can see some aspects that have to do with the activation of the endothelium that can be activated by different inflammatory cytokines like tumor necrosis factor, interleukin-1. Okay, then as we move on, we are going to enter more in details about the cytokines. Specifically, these tumor necrosis factor and interleukin-1, which are released by macrophages, okay, will induce the expression of adhesion molecules in the endothelium. These adhesion molecules, as the name says, they are to allow the adhesion of something. Okay, maybe another cell, platelet, or a neutrophil, or a monocyte. They have different names, integrins or selectins, okay, that will grab the endothelial cells before moving by diapedesis into the tissue that has inflammation. When we have an activated endothelium, instead of anti-thrombotic, anti-inflammatory, becomes pro-thrombotic and pro-inflammatory. Okay, there we have some steps, okay, that we can see in cases of endothelial activation. Okay, any injury will activate the endothelium, leading to increased permeability, adhesion of leukocytes, increased separation between the cells. Notice that in some cases, for example, imagine someone who has excess cholesterol. Cholesterol will enter under the endothelium, lipids of different types, and you have this mixture of cholesterol and free radicals and oxidation reduction reactions. So part of this cholesterol may get oxidized. Okay, you have heard a lot about HDL, LDL. Okay, one thing is LDL, which is a low density lipoprotein that takes cholesterol to the liver. And another thing is oxidized LDL. Okay, for our body, LDL is a normal particle. Our body is not going to attack LDL. A macrophage sees a particle of LDL and says, hi, say hello to the liver. But oxidized LDL is a totally different thing. That shouldn't be here. And macrophages eat it. And another, and another, and another, and another. So this oxidized LDL is the one that will accumulate within macrophages under the endothelium. And then more macrophages will come, more LDL oxidized, etc., forming the atheroma plaque. Now we may see in the coronaries, or we may see in the carotids, or different parts. Okay, that is it's a process very complex. It's not only that. Okay, you have there many other factors, for example, vascular endothelial growth factor, platelet-derived growth factors, cytokines, coagulation factors, many things. When we reach the cardiovascular pathophysiology, we are going to talk about this in more detail. But look at the right side. Look at the difference between a normal endothelium. Okay, it looks like having grass on top, or hairs, no? Notice the separation that exists between the endothelial cells and the vascular lumen. So the blood cells are circulating here, far away from the endothelial cells, very far away. And all these fibers, hyaluronic acid, glycosaminoglycans, all of them have negative charges. So they will repel the cells. Cells can get even close to that area. Now once we activate the endothelium, notice how the glycocalyx of the cells is gone. Now the cell membrane of the endothelial cell is exposed to the blood circulation, and then we have the expression of adhesion molecules that will serve the platelets, neutrophils, monocytes to attach and move into the tissues that have any damage. Okay, and that's where the process starts in many conditions. So we have to mention the role of different cells, but this is something that you have, I'm sure, studied many times in the past. Neutrophils are the ones that go first when there is an acute infection. They live very short lives. They produce pus. Okay, when you have a purulent lesion, okay, you know that for sure there are neutrophils, dead neutrophils. Not necessarily bacteria. Okay, you are going to see some types of conditions. There is a type of psoriasis in which people have many lesions that look like having pus, are yellowish. If you analyze that lesion, the content of those lesions, there are no bacteria there. Simply neutrophils, dead neutrophils. Okay, that is not infectious. Eosinophils typically participate in allergic reactions, attack parasites. Mast cells are resident cells. That means they are always localized in different tissues. Okay, immune system cells are divided into residents and circulating. Okay, resident cells are the macrophages of the skin, the microglia of the brain, the Kupffer cells of the liver, alveolar macrophages, the mast cells that are on the skin, dendritic cells, they don't move, they're just there. And the circulating cells that are in the blood and move from here to there, from the spleen to the, maybe to the brain, to the lymph node, to another lymph node, they are patrolling the body. And basophils also participate in many allergic reactions. They amplify the inflammatory response. Okay, these cells contain granules, that's why they're called granulocytes, that contain many different inflammatory mediators, histamine, heparin, toxins to kill pathogens, enzymes to synthesize prostaglandin, leukotrienes, cytokines, chemokines, different signal molecules. And the other type of white blood cell is the A granulocyte, so no granules. Okay, the circulating cell is the monocyte, that once it goes to the tissues and is activated, it becomes a macrophage. Okay, monocytes are inactive. Okay, when they receive a signal, move and become macrophages. Macrophages go to the place of infection once the acute infection is over. They wait for the neutrophils to finish their task, and then they go eat all the debris, and then they switch their role, and they start repairing the tissue. They start sending signals to repair the tissues. They activate fibroblasts, for example, or other cells to repair the tissue. Then we have lymphocytes, can be T cells or B cells. Another type of lymphocyte is the natural killer cell, but that belongs to the innate response. T cells are in charge of the cellular immunity, okay, attacking infected cells, damaged cells, regulate the adaptive immune response, and the B cells are the ones that make antibodies once they mature into plasma cells. And this is going to be all for today. Okay, the rest is going to be in the next encounter. And well, hope you learned a lot. You're welcome. For you.
It's alive.